Right. So remember, for every recorded academic session in the UK, this is guided by NHS and national GDPR laws. So if you want to share it, make sure it's for the appropriate audience, the appropriate group, and to be used for academic purposes only. Thank you. So Henry, you can carry on.
Thank you very much, Obi. Good evening, everyone. I also recognize GP colleagues here, Dr. Chogu, Dr. Ariva, and all the GPs. Welcome, everyone. As Obi has introduced, I'm a GP. I work in Northampton in the East Midlands. In addition to the other roles which has been mentioned, I am an associate dean in health education East Midlands, and one of my areas of responsibility is overseeing AKT supports across East Midlands. I work with one of my colleagues, Dr. Mills, in doing that. So just in case you were thinking, why am I talking to you about the AKT? That's the reason, is because that's sort of what I do on a regular basis. I'm very pleased to hear lots of ST1s here. I think you chose it's good that you're thinking well ahead of the AKT, and I'm hopeful that the information you get today would be helpful it will be helpful to you in preparing for the exam. Okay, so this is the outline for today. We're going to look at the overview of the AKT. We're going to talk about why trainees need support with the AKT. It's important to understand why trainees fail the AKT, but more importantly, how to prepare for the AKT. And we're going to look at some tips on exam techniques and high yield topics. And I'm going to leave you a link of some resources that would be useful. Okay, so overview of the AKT. So the AKT is an exam that is taken from ST2 onwards in GP training, and it's a summative assessment of ability to apply knowledge in UK general practice. Now, two things I want to draw out from there is that it's a test of your ability to apply knowledge, not a test of knowledge. And this is one of the reasons IMGs fail a lot, because up until now, we've been used to test of knowledge. Give me 10 courses of this and you rattle and all of that. The AKT does not do that. So for example, you're not going to get a question on how would you manage impetigo, for example. What antibiotic would you use to treat impetigo? The way the question might be phrased is there would be a picture of a child that's got impetigo, and they give you a brief history. This child's mom reports that 3 days ago, he developed this rash, which has now progressed to this, and a little bit more history. And they say, which of the following is the most appropriate medication of choice? So you first have to recognize that rash, that it's impetigo. And when you do that, then you then have to tap into your knowledge of what antibiotic you use to treat it. So that's the way the AKT is usually structured. And it's important when you are preparing to make sure that your knowledge is in depth so that you can be able to apply it regardless of how the question is phrased. The second bit is that it's about general practice. So UK general practice. The questions are such that there will be things you will commonly encounter in UK general practice. And that's why the evidence is that if GPs do the AKT exam, majority will pass even without notice, because it's a question that tests general practice. If you give them like a week to prepare, even more would pass. So trainees, that may come strange to trainees, but because the question is about UK general practice and they are set by GPs, so the more knowledge you have of UK general practice, the more likely you are to pass the exam. It's 200 questions over 190 minutes. That's an average of 57 seconds per question. So that's a very time pressured exam. You really have to build your stamina. It gets tougher because you don't get a break. It's the 3 hours, 10 minutes just goes on, and you really have to build your stamina coming to the exam. 80% of the questions are on clinical knowledge, 10% are on evidence-based practice, otherwise known as medical statistics, 10% on primary care organization and management issues. Now, it's important to remember this split because you cannot pass this exam if you don't pass the clinical knowledge. So even if you get 100% in stats and evidence-based, if you fail the clinical knowledge, you cannot pass the exam. So some people give too much attention to stats. It's still just 10% of the exam. So overwhelmingly, the clinical knowledge element should take the biggest portion of your preparation time because that's the one that would determine whether you pass or fail the exam. Now, it's possible to pass the clinical knowledge and fail statistics or management and then not pass. So you still have to give the attention. That 10% is not insignificant, but you have to plan your rota in such a way that you give more attention to the clinical knowledge bit, okay? So the questions are mapped to the RCGP curriculum, including the latest update. And this is the challenge about the exam, because the RCGP curriculum is probably the widest curriculum across all the colleges. And pretty much all elements or nearly all elements of that are tested. So in preparing for the exam, you cannot, back in medical school, sometimes you take a gamble and say, I'm going to prepare on this topic. You can bet that the teacher will bring it out and maybe you're lucky. The AKT is not like that. You've got to really cover the curriculum and make sure your knowledge is in depth in terms of the curriculum if you want to stand a good chance of passing. Now, the AKT employs a variety of question styles. The commonest question types is what's called the single best answer, which is your typical MCQ question, best out of 5. Then there's what's called the extended matching question, where you're usually giving a list of options, which can be anything from 8 to 12. Then there are 2 to 3 questions that are attached to those options, and you're supposed to choose from that list what's the right answers. And they would say that you can use each option, you may use any option once, more than once, or not at all. And you're supposed to choose from that list. Then there's what's called the multiple best answer, where usually in the AKT, it's a question that's got 6 options and you're asked to choose the correct 2 options. Sometimes, or unusually, there's the free text option, a question where they ask a question and there's a space on the system. They say, type in your answer. And the answer will be so obvious that everybody that gets it right will be one correct answer. So something like, which is the usual first-line medication for managing diabetes, type 2 diabetes. So everybody will know that's metformin. So you type that out. Or a calculation question where the answer can only be one thing. Then there's calculations. The calculations are usually simple calculations. They are not the type that you're going to need anything more than a simple calculator for. And on the day a calculator is provided on the screen for you, if you're beginning to calculate anything more than simple calculation, then know that you have missed the instruction. It tends to be something around drug dose calculation and those sort of calculations. Increasingly, there's the use of graphs and charts. So many of the statistics questions are around use of graphs and charts. And a lot of trainees struggle with these, mainly because they are not used to this. I think the best way to prepare for these is be used to reading things like journal, the British Medical Journal, the British Journal of General Practice. Be used to checking those emails that your ICB send around prescribing data and things like that. It's usually those sort of things that they put in the exams. But if you've not seen them before, then they become a little bit of a challenge for you. Okay, the pass mark is variable with each exam, but it's often nearer the 70% mark. So since the beginning of AKT till now, the pass mark has been between 64% to 72%. So 64 is the lowest, but that was a long while ago. Recently, the pass mark tends to be around 71%. 72% is the highest the pass mark has ever been. So really, if you want to pass the exam, you want to be scoring 72% or more to make sure that you would definitely land on safe ground. You are allowed a maximum of 4 attempts. I would say for now, there's a likelihood that in the near future, that's going to increase to about 6 attempts. But as of today, it's a maximum of 4 attempts that is allowed, except what's called an exceptional case where an argument can be made for a 5th attempt. But you don't want to get that far. You want to nail the exam the 1st or 2nd attempt at most. Hence the reason we're doing this. So here's an example of a single best answer. This is a question that is available, that's been made public by the AKT core group to help people in their preparation. So this is a typical example of your MCQ question. The question is there. You then have a list of 5 options and you're to choose the most correct one. So this is an example of a single best answer. Now, in case you were wondering, the answer is idiopathic for that. Okay, we're going to move on to the next one, which is EMQs. So this is an extended matching question. You can see 8 options are listed, and then you've got 2 questions. So you're supposed to read the question, then look on the list for the answer and select the right answer. So the first one is about a 10-month-old girl. The second one is about a 15-year-old boy. So this is testing your knowledge of epidemiology of the likely causative organisms for common infections you see in general practice. Here's an example of a calculation and a free text question. This is simple if you're used to it, but sometimes it trips people up. So this is something testing your knowledge of prescribing for children. And here you're going to do the simple calculation. You can even do this without a calculator, and then you're going to type the answer in free text there. So that's an example of a calculation and free text. This is an example of a multiple best answer where there are 6 options and you're supposed to choose the 2 correct ones. Because of time, I'm not going to be going through the answers today. So just so that we can cover enough ground. But these questions are on the RCGP website on the AKT page. And in total, there are about 53 questions there that you can use to practice. So that's an example of an MBA. Okay. Now, why do trainees need support with the AKT? Now, in the graph there, you would see the pass rates for the 4 nations in the United Kingdom between the year 2014 to 2021. So this is pass rates at first attempt. So when you look at that, the average pass rate in that 7 to 8 year period is about 72%. So what that means is that across the UK, nearly 3 out of 10 people failed the AKT at the first attempt across the whole of UK. Now, some countries are doing better than others. Northern Ireland doing the best there. I think that may just have to do more with numbers, really, than anything else. But that's an idea of what happens across the country. Now, if you bring it down and break it to the nation of primary medical qualification, you would see that although the national average is 72% over those 8 years, amongst UK graduates, it's about 83%. So with UK graduates, more than 8 out of 10 are passing the exam at the first attempt. So you know what's coming next, okay? If the average is 72 and UK graduates are getting 83%, so there's definitely a group that is not scoring as highly, and that group is the international medical graduates, okay? And you can see in that 8-year period, the pass rate amongst international medical graduates, first time successful attempts, is about 48%. Okay, now look at Northern Ireland. That's less than 30%, 29%. So that's really, really ridiculous. Okay, so this is why people need support with the exam. There are several reasons that could adduce for this. We're going to talk about some of them today. But like I said, you're here early, you're getting this information is to help you make sure that we up that pass rate. So why do trainees fail the AKT? There are several reasons that have been adduced. Some we know anecdotally from sort of our experience of training people. But there was a study that was done in 2014 in East Midlands by the University of Lincoln. And they got trainees, a mix of trainees, UK graduates who are Caucasians, UK graduates who are BAME, and international medical graduates. So they mixed the group and they got some retired AKT questions, so some questions that had just been taken out of the pool for AKT, and they got them to do like a mock AKT exam. But the difference was that they were observed as they did the exam. And after they answer each question, they are asked a series of questions to try and get their mindset, the thinking behind how they answer those questions, how they approach it. So it gave an insight into sort of real life performance, what happens when people are doing the actual exam. And here are the things they came up with. They came up with 4 different themes on what makes the difference between whether people pass or fail. So the first thing they came up with was the difference in theoretical versus real life clinical experience. Now, although this is a knowledge or test of application of knowledge exam, what people, when push came to shove in the exam setting, when people needed to answer questions, what they found most useful was their clinical exposure, not so much what they had read. If they had been exposed to patients that presented with conditions similar to those that were being tested, they were able to do better. The greater the exposure they had to patients in that clinical category, the more they were able to recall. And the inverse was true. The lesser the exposure, the less the ability to recall. The specialties where people had limited exposure, they performed poorer in those ones. So if you had done a post in general medicine, for example, you were more likely to perform better in general medical post than if you are now exposed to psychiatry and you didn't do psychiatry, or those more specialized aspects of general medicine like rheumatology and those things, if you were not exposed to those. So limited exposure to specialties meant poorer performance, and learning methods affect performance. Now, particularly with IMGs that we are used to rote learning, you know, memorizing things. Exam is tomorrow, you cram it today and just go and download tomorrow. But then you get there and there's no question asking you to download anything, and that becomes a challenge. So right from when you're preparing, you need to be preparing for the exam as a test of applied knowledge. And the meaning of that is no shortcuts. You need to know the things in and out so that in any way you're asked the question, you know the answer. Now, the other thing was about recency, frequency, opportunity, and relevance. And this is about how soon or how long ago were you exposed to that sort of condition in your normal practice. So say, for example, maybe you used to be a specialty registrar in ENT in Nigeria 8 years ago. 8 years down the line, you are now in GP, you didn't get to do ENC as part of your GP rotation. So you now see ENC questions, you will struggle more because you've not been exposed to that area for a while. But if, let's say, you have just finished your general surgical post and you're doing your exam 3-4 months later, people were able to recall better in that. And in areas where they had repeated exposure, they did better. So the point here really is, generally amongst trainees, we see this attitude of, I'm going to do the AKT and I will pile my annual leave and I'll take 3 or 4 weeks together just to read before the exam, and you think you're giving yourself the best chance. Actually, the best way to prepare is to be seeing patients, identifying your knowledge gaps, and reading to seal that gap almost immediately and consolidate it when you see another patient. So you don't want to leave your preparation till the end. You want to be doing your reading and seeing patients at the same time, doing it together. That's the best way to consolidate your knowledge, okay? There were issues around gender barriers. Male trainees struggled more around issues relating to women's health, and that's because many male trainees, you take the sort of lazy approach of, this one needs PV exam, I book with female doctor and all of that. You're not doing yourself any good there. Book them with yourself, get a chaperone and examine and learn the beat, learn how to manage menopause, learn how to manage bleeding disorders, because you will be tested in the exam. Similarly, females would say things around men's health, prostate and all of that. I struggle with those. You need to know those things. So that's the bit about gender barriers. Now, statistics was an area of difficulty for both UK graduates and international medical graduates, but more so for international medical graduates. And the reason is not far-fetched. We hardly have any foundation in medical statistics, as it were. So we struggle with that. Okay. Competence and insight. So this is about how people judge their competence and insight. And to some extent, as in the exam, what that study showed is that people had wrong perceptions of their competence and insight. So sometimes they see some question and they say, oh man, this is up my street. I know this like the back of the palms of my hands, and they still choose the wrong answer, as it were. And sometimes they gave wrong evaluations of themselves. So it's important to really know where you are in terms of your knowledge, have an insight into your level, and make sure you are addressing those knowledge gaps. Don't be too confident about certain aspects because it's not a test of knowledge, it's a test of applied knowledge. Then this fourth category was more peculiar to IMGs, not UK graduates. So bits about cultural barriers, unfamiliarity with the NHS, not being used to national guidance, the exam format being a bit different, abbreviations that are used not being those that you're conversant with. Now, since this study, the AKT group have made some changes in terms of those abbreviations. So that's unlikely going to be a problem going forward. Okay, so this is why trainees fail. So the lesson really from there is that in your preparation, take account of the fact that it is an applied knowledge test. Know that your greatest way of learning is by seeing patients, and maximize your clinical exposure, especially your GP training, your actual GP post. That's the one that is going to be most relevant for you. Okay. In terms of preparation, this is sort of like the pyramid that covers how you prepare. Now, at the base of that pyramid is trainees preparation. That's the biggest part of the preparation, is the work that you're going to do. Now, your trainer may support you. Your local program may have some AKT support. The deanery may have something they do across the patch. eMedica, Aurora, and all of those, they may be there. But at the end of the day, really, the biggest preparation has to be done by yourself. All of these other things are just additional. So you must put in the effort, and that's important. Now, let me just have a quick look at the, okay, that's fine. So how do you prepare for the AKT? We're going to look at a few things. The first bit is about timing, okay? The timing of the exam is critical. Now, you can do the exam from ST2 onwards, but it doesn't mean that everybody should do it at the first attempt in ST2, like October. For a lot of people, that may not be the right time, okay? So the timing for you will have something to do with looking at your whole ST2 post. When is the right time? So if you are doing pediatrics or general medicine from August to December, October is not the right time for you, or you're doing A and E. You need those sort of posts that give you time to be able to prepare. So the AKT core group has advised that the best time to do the exam is during or after your GP post in ST2. During or after. One, because you need that exposure to GP. Okay, many of us do some bits of GP in ST1, but half of the time in that we don't even know what we're doing. We have not found our feet, as it were. So it's all new to you. But when you come back to GP again in ST2, you get more exposure, and this time you're hitting the ground running and you're accumulating that experience. Probably you are now even consulting at 20 minutes. So you're seeing more patients. That's how you learn. So you want to defer your attempts for when you are in GP, in ST2, or shortly after then. You've got the best chance of passing. Now, the other advantage that doing it in GP offers is that in GP, you have time for private study. So that would be instrumental in terms of your preparation for the exam. So timing is critical. The other thing I would say about timing is if something is not going right in your life, so maybe you've planned that you're going to do it in January, and then December, some crisis starts. Don't just rough your way through it and say, I'm going to do the exam, because don't underestimate the impact that's going to have on your ability to perform and prepare for the exam. You're better off deferring the exam. Now, even if you have paid for the exam, you can contact RCGP and say, I want to move it to the next time, rather than going to say, let's see how it goes on, and then you get a fail against your record. So you will lose some money. I think you're going to lose about 20% of the money, but it's better than getting a fail against your record. So you want to make sure that you're in the best headspace for when you want to do the exam. Now, effort is important. You need to put in the effort. You need 3 months of preparation for the AKT exam minimum. 3 months minimum. And that's 3 months of doing nothing less than 1 hour of focused AKT study in per day in that period. So we're talking about 80 to 90 hours of preparing. That will enable you cover the curriculum, practice your question bank, do mock exams, and feel ready for the exam. So do not underestimate the effort that you need to put in, okay? Don't crash it into 2 weeks, 3 weeks. I can tell you from experience, it does not work. It doesn't work. So 3 months, give yourself. If you are known to have neurodiversity, dyslexia, dyspraxia, anything of that sort, you need double the time. You need 6 months to prepare for the exam. So effort is important, okay? You need to track your learning. You need to be identifying knowledge gaps and covering it. So either from debriefs in surgery, that's a good way to identify knowledge gaps, and you can make a plan with your trainer, say, please, can we cover this subject in tutorial, or I'm going to read this up and do e-learning. That's one good way. Another good way to track your learning is mock exams, those question banks. Doing those question banks can expose the areas where you're lacking. Now, the pitfall that you need to avoid is don't just read that small summary that the question bank will give you and think you know that subject, okay? If you identifying that an area is an area of need or deficiency, go and read that area comprehensively. The summary that question banks give are not enough. They are just enough to answer that question. They are not in-depth enough for you to be able to answer any question that comes around that area. So you want to be tracking your learning and making sure you're meeting those needs. You want to be doing timed mock exams, okay? This is one about building your stamina. 3 hours, 10 minutes is a long time to just sit and be doing an exam. So if the first time you do that is on the day of the exam, you'll be too tired. So you want to build your stamina before then, but also you want to be covering and seeing how well you're doing with those question banks. Now, one of the problems that for people who fail the AKT is an over reliance on question banks. You go through past medicine and they say you've been through it 3 times, and now towards the exam you're getting 90% and you feel like you're ready. Well, what that just tells you is that you've known past medicine so well that you're getting 90% there. But the exam on the day is not going to be past medicine. In fact, the examiners know that you rely on past medicine, and sometimes that can become a trap for you. That once you read the first 2-3 sentences, you think, oh, I've seen this before. And very quickly you're jumping, you're looking at the options, not knowing that the examiner has changed one word or one sentence there that gives a completely different answer. So you don't want to get too familiar with question banks. Use them as they were intended to build your stamina and to identify knowledge gaps. Still do the reading to be able to know the bits in total. Study groups are important and they are helpful. They would help you split some of the work. So for example, things like nice guidance and all of that, you're better off sharing those things amongst yourself and letting somebody come and do a presentation to the whole group and drawing out the important points. It's more time efficient that way. You can practice past questions or question banks together and begin to see about techniques and help each other in that regard. So study groups are useful in that regard. Using the right resources. Now, the RCGP on the AKT page of the RCGP website has written a list of what is the right resources, how to prepare for the AKT. You want to make sure, the link is at the end of my presentation. You want to make sure you read that page. That page is probably going to take you about 2 hours to 2.5 hours to go through. You want to go through every information. Now, sometimes there's trainees rely on what other trainees tell them and not what the people who are setting the questions are telling them. So go to the RCGP website. It's an open book. They've told you what you're going to be tested on and how to prepare for it. Read that information, is useful. That's how you're going to be able to know you're using the right resources. Okay, so resources that you can use. Here's a suggested list, and these are not from me. This is from the RCGP. So starting point, the RCGP page on the AKT exam is where you want to start with. Oxford Handbook of General Practice is advised as your main text, especially for your clinical knowledge and for part of your admin organizational bits, the Oxford Handbook. So you want to read the Oxford Handbook from cover to cover to really, really update your knowledge. That's your main reference text. Reading up on topics where you've identified a knowledge gap. If there are guidelines available in that area, you want to be reading those guidelines, okay? So you make sure, and you want to make sure that the sort of bread and butter bits of GP, you know hypertension, you know diabetes, you know asthma. Those things are at the back of the palms of your hands because you cannot escape questions from those, okay? You can arrange for NICE to be sending you their update for primary care every month. So every month, NICE can send you a list of the guidelines that they have released that month that are relevant to primary care. Because the exams are going to test you about latest updates too. So if a change has come in within the last 6 months, you can almost be certain that it's going to show up in your exam. So, and especially if it's a national thing, okay? You want to be completing what's called the RCGP Essential Knowledge Update. I'm amazed at how many trainees don't even know this exists, okay? Every year, the RCGP releases what they call an Essential Knowledge Update 3 times a year. And it's usually 5 topics that are relevant to primary care, and they will give you the most up-to-date evidence in those 5 topic areas. Now, those updates are written by AKT examiners, and they are also the ones that write what's called the Essential Knowledge Challenge. So after each update, about 1 or 2 months later, they release what's called a challenge that is like a mock, an exam on those essential knowledge updates. Now, before you do the AKT, you want to make sure you go through the essential knowledge updates and essential knowledge challenge of about 2 years leading to that point in time, okay? So you go through the updates and you go through the challenges. You can do that in one of 2 ways. You can either read all the updates and then do the challenge, or if you're struggling with time, you can do the challenge first and identify the areas where you have done badly and go to the update and go and read it up, as it were. Either way, the important thing is to cover the essential knowledge updates and the challenge. Okay, BNF, you want to review BNF chapters. Now, with the BNF, you don't have to read it cover to cover, but the first couple of chapters are important that talk about important drug categories, important drug interactions, important side effects that you should be aware of. You want to read those and be familiar with that. Year after year, the feedback is the same, that trainees struggle with that area. So you want to know that very well. And then every exam, the RCGP gives a feedback report. And the feedback is about areas where trainees have done well or have improved compared to previous exams, and areas where trainees continue to struggle. Now, you may have heard of something called high yield topics. Now, those are your high yield topics. Areas where trainees continue to struggle are your high yield topics, because knowing that trainees struggle with it, the core group are going to keep testing those areas. And by the time you read 3 consecutive feedback reports, you will easily know what the high yield areas are, because consistently, so things like dermatology, pharmacology are consistently areas of struggle that trainees struggle with. So you want to know those areas. Okay, very quickly now we're going to look at exam techniques. So I've talked about how to prepare, why people fail, and the differential attainments in it. So this is about techniques that are useful for the actual exam, okay? The most important or most common technique that you're going to need to use is what's called the cover test technique. And this is, do you know the answer even before you've looked at the option, okay? So when you see a question, it's not time efficient in the AKT, especially the single best answers and the extended matching question, to go through the option first. Just read the question and think to yourself, do I know the answer? What answer has popped up in my head? And now that you have an answer in your head, look at the list of options. If the answer is there, okay, choose it. 9 out of 10 times, you're going to be correct, okay? If you go too technical and start to walk through each question to try to, each option to try to eliminate them, you're going to be wasting time and you're going to distract yourself, because the other options there are put there as distractors. So they are close to correct, but they are not the correct answer. So you may start overthinking it and end up choosing the wrong one. So if an answer pops up in your head and it's on the list, choose it and move on. That's what the cover test is about. And that's one good strategy for managing your time in the exam. So here's the question. So this is the bit where I need you to start participating now. A 63-year-old man with hypertension suddenly loses vision in his left eye. Visual acuity is hand movements only on the left and 6/6 on the right. Fundoscopy shows flame-shaped retinal hemorrhages. What are you thinking of? What comes to your head straight away now? Anybody?
Hypertensive retinopathy.
Okay, any other person? Now I'm going to give you a hint. Flame-shaped retinal hemorrhages is the key there.
Crow.
Sorry?
Central retinal.
Arterial occlusion.
Retinal arterial occlusion, crow. Have you seen our review then?
Yes, good. So that's what comes to your mind, is it? Now look at the list of options. Is it there? That's correct. So central retinal vein occlusion is what comes to your mind. And if you think about it even before you look, it's probably correct, okay? There will be other things. So like in this question, this is another AKT question. There will be acute glaucoma. There will be central retinal artery occlusion, which is, I think is what somebody mentioned. So you've got to definitely be sure it's central retinal vein occlusion. So that's a cover test at work. Is the answer, does the answer come up to your mind? Is it there in the list of options? Just pick it and move on, okay? Here's a question on weakness. A 35-year-old woman has noticed increasing weakness and numbness in her legs over the past few days. Today, she's feeling short of breath on exertion. 6 weeks ago, she had diarrhea and stool culture confirmed infection with Campylobacter jejuni. She was treated with Cipro and recovered fully. Okay, what are you thinking of already?
Guillain-Barré.
Guillain-Barré,
Yes.
absolutely. Guillain-Barré. Now, look at the list of options. Guillain-Barré is there, fine. You move on. You don't bother walking through the other options. The answer comes up, is there, choose it, move on. If the answer doesn't come up in your mind, you probably don't know it, then you may need to start walking through and eliminating. But if the answer comes up and it's there, choose it, move on. Okay? Other questions may require you to be able to spot the diagnosis immediately. So some questions will require to have good knowledge of pictures and images that you will commonly see in general practice. So things like dermatology, ENT, ophthalmology, genetic pedigree symbols, those would usually require use of pictures and images, and you're supposed to know those quite well. So these sort of questions, they are the type that you either know or you don't know. So it's important to get quite familiar with them. Okay, so look at that picture, and this is the question. A mother brings her 24-month-old boy who has developed a rash as shown in the picture. They ask you what the rash could be. What is this rash, anybody?
Impetigo.
Impetigo, okay? So you've got to recognize that straight away, okay? That's the question there, and you choose the answer, okay? Rote learning. Now, although I have mentioned that the AKT is a test of applied knowledge and rote learning is not the best way to prepare for it, there are some topics that really there's no way around than to memorize it in terms of rote learning. You just have to memorize it. So, for example, those sort of questions may be the type that you use mnemonics for, or that you use aid memoirs that may help you to remember them. So things like vaccination schedule, emergency drugs, sick day rules, developmental milestones in children. There is not, unless you have a child of your own that you can remember the milestones, there's really no other way around it. You've got to memorize those and download them on the day. So be mindful of topics like these that require rote learning. The important thing is that don't leave them too late. Read them before the exam and review them again some days before the exam so that it's still fresh when you come to the exam. So here is an example of that. Specialist referral is appropriate for which two of the following children? Select two options only. So can anybody tell me what two options they are going to choose for this?
D and F.
B and F, yes, that's the correct answer. Is B and F, B and F. So
Okay.
4-month-old girl who cannot grasp an object when it's placed in her hand. So this is not checking for the ability to grasp, which many children develop around 6 months. This is more about grasp reflex that is present from birth, okay, when you place the object in the hand. So B and F is the correct answer, okay? Some questions will be about interpreting signs and symptoms, okay? You need to be able to interpret signs and symptoms. So it's not just about the history, there's the bit about signs and symptoms. So the questions can come in the way of mixing clinical history with examination and test findings. And you need to be prepared to incorporate the two information together in order to be able to reach a diagnosis and management. Okay, so for example, the clinical finding or results of investigation may seal what you're already thinking in your mind. So the history is already pointing you in a particular direction, and the information they then give you about clinical finding or test results may then confirm what you're thinking. Or the clinical finding or test results may change the answer completely from what you're thinking about the history. Hence why it's important to read the full question and incorporate both elements, the history and the clinical examination. So here's an example around anal pain, okay? For the past week, a 30-year-old woman has noticed fresh blood on the toilet paper and experiences sharp pain around the anus when she defecates. Now, what are you thinking of here?
Anal fissure?
Yeah, probably. Yes, that's what you're most likely thinking. It's painful. There's fresh blood when she defecates, okay? On examination, you can feel a very tender lump at the anal margin. What are you thinking now?
Thrombosed hemorrhoid?
Yeah.
Absolutely. Now you see how the examination has changed what you're thinking. Initially, you were thinking anal fissure. At the examination, say on examination, you find it here at 6 o'clock, that will confirm anal fissure. But now it's telling you, you find a tender lump at the anal margin. So what's the single most likely diagnosis? You can see anal fissure is there just in case you read only that first part and went to answer the question. But thrombosed hemorrhoid is also there, which is the correct answer. Okay, so incorporating the two would be important in passing. Now, the other bit is what's called distractors. Okay, the best questions that separate the passing from the failing candidates are ones that contain good distractor. Okay, so a distractor is another option that is incorrect, but it's enough to make you doubt your choice of the correct answer. So the option is incorrect, but it's there enough to make you doubt your choice of the correct answer. And this is very good at separating passing from failing candidates. So sometimes there will be questions where you have to narrow it down to 2 to 3 very good options, okay? 1 or 2 you may be able to eliminate those. When you have those sorts, you need to think to yourself, what is the most likely in this patient in terms of probability going, if you think epidemiology-wise, what is likely? So for example, in a 25-year-old female that has a new onset dyspepsia, what's more likely? Is it reflux or gastric cancer?
Good.
Reflux?
Absolutely. So just going by age, epidemiology, reflux is more likely in that age. Also think to yourself, what's the most serious that you shouldn't miss? Because this exam too is about testing your safety, okay? in a 65-year-old female that's coming with new onset dyspepsia, are you thinking reflux or are you thinking gastric cancer?
Gastric cancer.
Okay, so that age difference of 40 years makes a difference in what you're thinking. So that's how you narrow down the options. Sometimes it's also what is the most appropriate, because the stem of the question is not always about what are you going to do to treat or what's diagnosis. Sometimes it's about management too. And management, doing nothing can be the right answer sometimes. So what's the most appropriate thing to do first? Generally speaking, in GP, we will do blood tests before we will do referral. So if you're seeing those options, you're more likely to choose a blood test than referral. Is doing nothing, watching and waiting, more appropriate rather than investigating or treating? Because sometimes too, they don't want you to overtreat. So a common one, for example, where people get caught out is that somebody comes with a history that suggests osteoarthritis, you do X-ray. Now, when you check NICE guidelines, it does not encourage you to do X-ray willy-nilly. You do X-ray if you're thinking that it may be appropriate to be worked up for a replacement or something of that sort. That's one of the times you do it. But the diagnosis you can make clinically, and you can tell the patient, you've got arthritis from my findings. You don't need to do an X-ray to confirm a diagnosis of arthritis. So that could be one where you are tested around. Are you going to jump for X-ray, or are you going to just give the patient the verbal diagnosis and treat them appropriately? Okay, so here's a question, for example, on end-of-life care. According to the current BNF, what's the single most appropriate antiemetic to use in a syringe driver with diamorphine? And this is select one option only. Okay, now look at that and just tell me how you might approach this in terms of eliminating distractors. And what would your answer be? Okay, so if I was to approach this, glycopyrronium is not an antiemetic, so I can eliminate that. Is used for managing secretions. So I'm left with 4 antiemetics. Now, in my experience in palliative care, all these antiemetics can be used, but 2 of them, I have only prescribed them orally, as far as I know. Okay, stemetil procopyrazine only gets prescribed orally. Domperidone gets prescribed orally. I've never used them for as in a syringe driver. So in my experience, that leaves me with ondansetron, levomepromazine. Ondansetron, the patients that often we will prescribe them for are those on chemotherapy that have chemotherapy-induced nausea. Okay, so for patients in end of life, the second line antiemetic that I'm aware of after haloperidol is levomepromazine. So on that basis, that's going to be my answer. That's how I would eliminate it. So even though I may not be sure of the answer from the onset, but by just walking through, first I've got rid of the one that is not an antiemetic. Then from my experience, the ones that are usually as oral before I come to the syringe driver one. And then of those 2, which one do I see used more often? That's how you walk your way through distractors. Okay. Best option. So sometimes a question in the AKT, multiple options will be acceptable, but the question is asking you what's the best option. So of all these multiple options that may be correct, which is the best of the lot? And the best is often determined both in terms of guidelines and in terms of common everyday practice. So sometimes the first choice will not be there based on guidelines. You need to think about what is the next best alternative. So it's testing your knowledge of, are you aware of guidelines? What does it say should be the first line? If that's not suitable for the patient, do you know what the next line should be? Okay, so here's a question. A 35-year-old man known to have a diagnosis of migraine on sumatriptan and naproxen reports that his medications are no longer controlling his symptoms. Examination is normal. What's the best medication to commence? Okay, what are you thinking of here? Going by guidelines for migraines. So we're looking at migraine prophylaxis now, okay? Any thoughts? Okay, most of you are SC1s, that's why. Very soon you'll see this quite often.
Propanolol.
Propanolol, okay? Propanolol is what most people will go to next. If propanolol is not suitable, do you know any other prophylaxis medication that is commonly used? Sorry?
Topiramate.
Topiramate, yes.
Topiramate.
Amitriptyline, those are also used, okay? So now you're thinking propanolol. Now, here are the options. Candesartan, codeine, sodium valproate, topiramate, gabapentin. So what are you going to choose here?
Well, if there's no pregnancy in the picture, I think topiramate will be okay.
Well, he's a
Yeah, he's a
35-year-old
man.
male. Do you think
Yeah.
he's pregnant?
Okay, sorry. I didn't check the sex.
Okay.
Then topiramate.
Topiramate will be, okay. So candesartan can be used for prophylaxis, okay, but it's unlicensed. So neurologists are the people who prescribe that, okay? In the same way as sodium valproate can be used, again, neurologists prescribe that. Codeine phosphate is not for prophylaxis, okay? And if anything, it can cause its overuse can even make headaches worse. Gabapentin, although is a neuropathic agent, so you can use amitriptyline, but you cannot use gabapentin. Gabapentin is not licensed as a migraine prophylaxis medication. So eliminating all of those, topiramate becomes your answer. So here, the common thing you use is not there, but it's testing your ability to know those guidelines in depth to be able to eliminate the others and choose the correct one, okay? So sometimes, again, the question is about varying level of difficulty. Know that potentially any question can be made easier or it can be made harder. So here's a picture that is there, okay? And I give you this history. I say a 60-year-old man presents you with a rash that's appeared over the last 2 days after walking his dog in New Forest. This is the picture. He has no known allergies or other significant medical problems, okay? If I want to make it easy for you, I can ask you, what is the diagnosis?
Lyme's disease.
Exactly. Lyme's disease. So most people will know that when you see that characteristic rash, okay? If I want to make it a little bit harder, I can ask you, what's the causative organism?
Borrelia something.
Yeah, Borrelia
burgdorferi.
Okay, so that took a little bit more time to remember than the diagnosis. If I want to make it a little bit more challenging for you, I'll say, what's the most appropriate treatment? Doxycycline, exactly. Okay, a little bit more challenging. What is the alternative treatment if the patient is allergic to doxycycline?
Azithromycin.
Azithromycin or amoxicillin is what the books say. So now you see that same question. Sorry?
I think they use flucloxacillin as well.
I'm not aware of that, but I'm aware of azithromycin and amoxicillin. Yeah. So that singular question, you see how I can vary it to make it more difficult or easier. So you need to know it in total in order to be able to answer it regardless of how it's asked, okay? And some questions will just be about narrowing it down. You may not have the idea of what it is, but it's testing your ability to exclude something rather than knowing the answer. So for example, an 84-year-old man has just undergone MVR with a mechanical valve, okay? What's the single most appropriate anticoagulant that you can use for this patient? Okay,
Warfarin.
warfarin. Yeah. So if you know it, that's very good. You know it's warfarin. But here, if you don't know it, you can try and walk your way. Okay, aspirin and clopidogrel are antiplatelets. They are not anticoagulants, so they're out of the way. Apixaban, dabigatran, warfarin are anticoagulants. Apixaban and dabigatran are DOACs. And as far as I know, none of them particularly has any advantage over the other one. They are both BD, their safety profile and side effect profile are fairly similar. So for that reason, warfarin is probably the answer. You can narrow it down that way if you don't know the answer. But if you know it, easy peasy for you. So these are some links for the resources that you can use that you would see it's being recorded. So once the video is shared, you see that. So in summary, AKT remains a high stakes examination. Okay, the failure rate is still high. Differential attainment exists. The failure rate is even higher amongst IMGs for all the reasons we've gone through. A focused preparation is required for success in the exam. I will be disappointed if any of you present here today still does the exam in preparing for the exam in 3 weeks, 4 weeks after all that you've heard. Take this information very seriously, okay? And use every single bit of tip that you've been given today in preparing for the exam. Thank you for listening. That's my email if you have any question after now. I know we've run over a little bit, but thank you all for listening. Any questions?
Well. Thank you so much, Henry. I must confess that even I, as a trainer, has learned so much from this. Reason is what I've learned, I can also apply in my daily practice. Yes, I won't be sitting the AKT anymore, thank goodness. But yeah, I always tell my trainees, for you to pass any exam, you have to prepare for it towards being a good GP. Because when you learn how to be a good GP, exams will just, you easily just go through the questions, you'll be relaxed, you'll pass it. So, yeah, I'll put what I've learned into this. So, yeah, I know we've, gone above time, but maybe we spend the next, say, 10 minutes to entertain questions. So Henry is a wonderful resource. You have him here. Go ahead, ask your questions before we make the final comments. Yeah, maybe we stop recording now. Yeah, shall we?
Yeah, I can stop it.
Yeah, because I'll share the So yeah, you can stop it. Okay, yeah, perfect.